Hello and welcome to On Becoming a Healer. 73 million Americans have some type of disability. Those range from bodily and sensory limitations to difficulty with learning or cognition. Stunningly, just 41% of doctors feel very confident that they can provide equal quality care to their patients with disability. Our guest today is an expert in both disability and healthcare and a woman with disability herself. Her name is Dr. Lisa Iezzoni, and I'll introduce her in a moment. But before we go further, I'd like to ask you, Saul, why are we touching on this topic today?
Thank you, Stefan. So first of all, I have to tell you that when I was preparing for this interview, I asked ChatGPT for some advice about questions, which I sometimes do. And ChatGPT actually told me that I was very fortunate to be interviewing Dr. Lisa Iezzoni. And that's a very new kind of compliment. I think it's something that's never existed before. And it's the first time that ChatGPT has said that to me. I think many of our listeners know Dr. Iezzoni's name and are somewhat familiar with her background. We could cover a huge range of topics today, but I wanted to hone in on one particular area. At least I'm hoping it's something that we'll touch on today. There are sort of two narratives that stand out for me when Dr. Iezzoni talks about her life and her work, and when one looks at it. On the one hand, there's the academic side of it. She spent a great deal of time doing pioneering research just on disparities in care and outcomes in people with disability. And in fact, her foundational research before that involved a lot of sophisticated methodologic work looking at risk adjustment and outcomes and so forth. So it gave her a foundation for doing this type of research. And more recently, looking at some of the attitudes of physicians and how those may contribute to some of the disparities we see. I think you just briefly alluded to that. So that's one sort of narrative. The other is her personal experience. Mm-hmm. As many know, because she's talked about this, she was diagnosed with multiple sclerosis as a first-year medical student at Harvard and went through a pretty awful experience as a medical student. And then subsequently, it profoundly affected her career. And this was before the American Disabilities Act. And it ended up just quite honestly having a very negative impact on her experience with the process of becoming a physician. And I think that that's not unique. I've talked about the fact that I have a learning disability. My experience was also, I think, very significant in some similar in some different ways. And I think that there's a connection between culture in which we train physicians and then the kind of physicians they become. And one of my intuitions is that there's something about medical training that makes us very insecure. And I'm not talking about people with disability. I'm talking about everyone who goes through medical training, which is that there's all this emphasis on being normative, on not being weak, on being tough.
Yeah.
And a lot of what Dr. Iezzoni experienced was being told, oh, you're not up to it anymore. You have a disability. You can't be one of us. And you can imagine how in a culture like that, young people are going to become increasingly uncomfortable with their own vulnerability. And I think that when we are in the presence of people with disability, I think it often is a reminder to us of the vulnerability that we all experience. And I think that that may be one of the reasons why people who become physicians become part of the problem rather than part of the solution. So I'm interested in getting Dr. Iezzoni's thoughts on this potential connection between the culture in which we train physicians and some of the things that we're hearing from physicians who appear from their comments to be almost repelled by people with disability. Now, I think there are multiple factors here, but that's one of the ones that struck me. And I say that because as a medical educator, primary care physician, I've just been struck over the years by the extent to which physicians fear engagement. They fear being open and comfortable and being themselves with patients. And they sort of adapt a kind of a veneer, a demeanor, the sort of white coat, holding patients at arm's length, being very professional, but not truly being themselves. And I've often felt that that's a sort of fear of vulnerability. And I think that when we're in the presence of people with disability, it may be a reminder of our own vulnerability. I think there are a lot of other reasons why there's stigma, but that's certainly one of the ones that interests me. And I'm hoping that during today's conversation, we can start to connect her personal experience with some of the findings that have come out of her more recent research on the way in which physicians often seem to stigmatize people with disability and how that in turn may contribute to the less than favorable outcomes of people with disability seeking medical care.
Yeah, I really appreciate that, Saul, as a setup. Our guest, Dr. Lisa Iezzoni, is a physician, a research scholar of health service delivery and measurement, and someone with a disability related to multiple sclerosis. She's currently a professor at Harvard Medical School. Welcome to the podcast, Dr. Iezzoni. May I call you Lisa?
Please do, Stefan.
I'd be really curious. I realize now you're a doctor, you were a scholar, but what were you thinking about as you were growing up? What did you think might come for you?
Well, I never wanted to be a doctor, and I'll explain to you why. My father had a pediatric practice in our house, and I would hear all these kids screaming. They were coming to get their immunizations, and so there were screams throughout our house. And I was thinking, nope, never, ever, ever for me. And so, in fact, when I went to college, I ended up at Duke University. I had two science courses I had to take. I chose Rocks for Jocks as one of them, geology. And then for the other, I chose biology because I just thought it was fun. And I kind of tortured my classmates who were pre-meds. But then Duke had this amazing 3-semester series of courses where you learned health policy. And this was in the mid-1970s when Ted Kennedy was talking about universal health care. Victor Fuchs had written his book about, how much it costs for medical care. And I was hooked. And so I was fortunate enough to get into what was then called the Harvard School of Public Health, do a master's degree in health policy and management. And while I was there, I was 22, I met these amazing physicians, including Bernie Lown. I mean, it's just amazing doctors who would talk to me about what do you want to do in your career? And they said, have you ever thought about going to medical school? And I said, yeah, I said, no, I don't want to do that. But they started talking to me about all the good that you could actually do, the wonderful ways that you could help people in so many diverse spheres. And so I had a little tiny studio apartment and a little tiny table in it. And I put a yellow pad on on that table. And I put a line down the middle of it. And I put pros and cons on one side.
Oh, my goodness.
Because remember, I had 2 science courses in my background, and to apply to medical school, I was going to have to do more. And so I kind of made a list of what the pros and cons were of doing a special student pre-med type of program. And finally, the pros outweighed the cons. And so I ended up doing special student pre-med, with 2 semesters of physics, calculus, organic chemistry, inorganic chemistry in 1 year. But during that time, to keep myself kind of fed, I was acting as the assistant to the master of Dunstra House, which was what
Yes,
Harvard
I
House
know
was.
it.
And so I had to cater parties. I had to go out and buy wine and do things like that. But I was living right along the Charles River in Cambridge, and I'd go out running. Wanted to be kind of keeping myself physically fit while I was doing all this. And I started not knowing where my legs were. I couldn't feel them in space. I started feeling as if there were tight bands winding around my chest. But these symptoms would kind of come and go. And I asked my pediatrician father, what should I do about this? And he said, well, why don't you go to University Health Services, which I did. And the person there was probably, a moonlighting kind of resident. And he said, well, you look healthy. Maybe you should go to a neurologist. And so I just kind of put it out of my mind. And I ended up getting into Harvard Medical School after all of that. And my first semester, I couldn't put it out of my mind anymore because I started walking into trees, walking into cars. I just started having really, really bad symptoms. And so the first neurology appointment I could get was the last week of the first semester at medical school, and a very kind neurologist who is still a close personal friend. And this would have been in December of 1980. Diagnosed me as a classic history of relapsing remitting MS. However, at that time, they didn't have MRI machines.
Yeah.
So I had to come back in January, and they did all sorts of tests that confirmed that, yes, I had MS. And as you noted, this was 10 years before the Americans with Disabilities Act was passed.
Yes.
It was July 26th of 1990. And the medical school was a pretty brutal place. I'll just tell you one story from that time. And that is at the end of my 3rd year, I was planning to apply for an internship as a residency in internal medicine. And Harvard at that time had dinners for students with leading luminaries at the medical school, with cheese cubes and sherry and dinner. So I attended one of those. And sitting to my right was a man who was the CEO of one of the leading academic medical centers at Harvard. And I told him a little bit of my story and asked him, what would your hospital think about having a resident who might need to do it in twice as long rather than, the usual time frame? And he steepled his fingers, paused for a second, and then said, there are too many doctors in the country right now for us to worry about training a handicapped physician. If that means that some people get left by the wayside, so be it.
You heard this as you were getting ready to apply.
Well, yes. And
My goodness.
husband at the time was actually a fourth-year student, and he was sitting across the table from me and heard this as well. So it was witnessed. Let's just put it that way. But let me also say that I'm talking about this period right now with a great deal of kind of assurance and energy and authority, which at that time I did not feel. I felt like a deer caught in the headlights. As I said, I haven't talked about all the kind of experiences that I had, but let me just say that I was kind of rejected by the attending and resident community. So I was not surprised when about 2 months later, my internship advisor told me that the powers that be at Harvard had decided that they would not write a letter of support for me to apply for an internship or residency. However, they said that they would pass the hat to chairs of medicine at Harvard Medical School affiliated hospitals and see whether they could put together a position for me that would not be board eligible. And they did. And they came up with a salary of $3,000
per what?
Year.
My God, sorry, can't. I had so many questions, but I'm now just trying to figure out.
At the time, the starting, intern salary was something like $26,000.
Oh my God!
And so that is what's called constructive dismissal, which is classic disability discrimination, where they do not outright fire you.
No.
But they make the circumstances impossible for you to stay. And so you voluntarily just kind of exit stage left.
Yeah. Did you, at this point, first of all, I'm seeing all these doors slam on your face, and you're in probably your 20s or something.
Yeah, 26 or so, yeah.
Which is just a horrific thing to imagine. But at this point, did you think, oh my goodness, the ledger paper that I wrote out the pros and cons on, it was a mistaken ledger. I got it wrong.
Well, I've often thought about what I would have done if I had known that I had lost.
Yeah.
Because, and this is probably going to be too in the weeds, but right now I have my MD degree. And yet I've been applying for research grants, but not in clinical areas. If I had a PhD, I would have been a lot more kind of competitive for the kind of research grants that I apply for. And so, in fact, if I had known and had coolly thought rationally, I would probably have said, okay, instead I'm going to do a PhD, but that was not the circumstance for me. And so, here I am.
Yeah. I mean, I'm an MD researcher, and that part I understand. There's actually, if you're not doing direct clinical research, you're disadvantaged a little bit. You don't have the same background.
Exactly. Yeah. Let me tell you the other thing that I'm disadvantaged in there, that if I do not have full funding, and I'm at an institution where I'm a professor, but I have no tenure. And so I have no financial support. A lot of other doctors who, run shy of funding for, a year or two will just add clinic sessions.
Yeah. The backup is there.
I have not been able to do that. Instead, I've had to cut my own salary.
I almost got the sense from reading about your story and trying to exercise intuition that the combination of not having clinical backup and of already having had doors slammed in your face in your 20s left you feeling like you needed to do double or triple what others might think they had to do in research. Is that true? Or
yes, I was afraid of being fired.
Yeah.
The entire time, and remember, I graduated from medical school in 1984. It wasn't until 1990 that the ADA was passed. So I left medical school with a couple of clear messages. One, was that I was a failure because they could not cure me.
That you were a failure. Wow.
Yes. Now, one of the definitions of ableism, which is disability discrimination, is the view that people with disabilities need to be fixed. They could not fix me. Therefore, I should never, ever talk about it. And so for
Silence.
a dozen years or so, I never, ever talked about the fact that I had finally seen sense when I decided to start using a wheelchair. I didn't want to fall anymore. So what a cool thing. But my friends thought I had gotten worse and it was terrible. No, it was that I was finally becoming rational about it. One of the people who I interviewed for a position after medical school said I would probably work 40 hours a week and therefore he would only pay me half the salary because they expected 80 hours a week. Well, I worked way more than 80 hours a week.
My God.
And I had a list of papers that I was writing on my whiteboard over there, and we ticked them off as I was writing them. But that was the academic currency that you need, right? That's how you get promoted in medical school. And so that's fortunately what happened to me.
As you went through this process, did you feel that the research world, the world of producing papers and getting grants, also looked at you with skepticism, or were you sort of home free to compete on the merits?
I was in policy space.
Yeah.
Okay. And I was actually extremely fortunate to have had the prior master's degree in health policy, remember, which I did from the School of Public Health. And I was also very fortunate in my timing because the year that I graduated medical school and was starting my research career was the time when Medicare had fundamentally changed the way that they paid hospitals.
Yes.
From a kind of you pay for every cotton ball to it's now a DRG, a case-based kind of payment. And I was also fortunate that I landed initially at a place that was part of two national groups that were doing research on Medicare payment changes. And so because of that, I was able to do research that was highly relevant to policy and took me down to Washington a lot. And I, was appointed to various committees and things like that. And so I felt like from that side of the world, I had gained respect.
Yeah.
Yeah.
Sounds like it was crucial. And I keep thinking of being in one's 20s and feeling like people have slammed doors in your faces. And that's an extraordinary experience. So it sounds like there was a pathway that you were able to create out of that.
But let me say that I did not independently create this. I was fortunate to find myself surrounded with interdisciplinary colleagues, statisticians, methodologists, and so we really worked as teams. And some of these people are still close friends decades later. And so, so that was really very influential in kind of supporting my ability to go forward.
Throughout all of this, it sounds like you didn't turn your eye initially to disability. You were, developing this expertise in the measurement of healthcare systems and in adjusting for case mix and things like that. But at some point, it sounds like you began to look at disability as an issue in the healthcare system. What prompted that for you?
Well, as I said, I was doing a lot of traveling. I was going back and forth to Washington in a scooter type of wheelchair. And I chose that type of wheelchair because I could easily put a suitcase right under my legs. It had a little basket that I could put stuff in, very handy. And people in waiting rooms and airports would come up and talk to me spontaneously. They just talk to me about themselves, their parents, their friends, people who they knew in their lives or themselves who had increasing trouble walking and really wanted to learn how to get some assistance with mobility. So when I became a full professor, and here I'm going to be a tiny bit arrogant, I was also the first woman full professor of medicine at my hospital, which was Beth Israel / Beth Israel Deaconess Medical Center. So not only was I the first woman professor, I also had a reputation for my health policy work that I thought it would be really hard for them to fire me. And so I thought, okay, now that I have this credential behind me and it would be hard for them to fire me, what do I really want to do? And I had looked to the general medical literature, not the physiatry literature or the, neuro literature or rheumatology literature, but I looked for the general literature about what general internists are being told about how to support people with mobility disability. And there was almost nothing out there. And so the Robert Wood Johnson Foundation at that time had a wonderful award called the Health Policy Investigator Award. And so I applied for one.
Yeah.
To do a mixed method study where I would do analysis of data that had recently been published by the federal government about disability, as well as do interviews with people with mobility disability and begin to kind of learn something about this field. And so that's how I got started.
I'm wondering if you could share with us some of the signals of trouble that you encountered.
The signals of trouble from people that my
From the
rural
health
focus group that I
Yeah.
would
What did they tell you was happening?
that would okay, that their doctors knew nothing about it, that they
Yeah.
were clueless, or that they strongly discouraged anybody getting a mobility aid. And I actually have the privilege of teaching an undergraduate class, a single class every year at Harvard to students where I'm supposed to be talking about how collaborative care is the right model for people with disabilities that they're working with as patients. And I always start that story with talking about how one day I was rabbiting past a hospital. And when I say rabbit, it's because wheelchairs have two speeds, turtle and rabbit. Okay.
Got it.
And I like to rabbit, if I can, without hitting anybody. And so I was rabbiting past this hospital, and this young woman was sitting out front with an IV pole with a cigarette in hand. And I figured she was probably an inpatient who had wanted to take a cigarette break. But anyway, she flagged me down and she described that she has diabetes and she's really having trouble walking. And she's a single mother and she has trouble going to the grocery store to get foods for her kids because of her walking difficulties.
Mm-hmm.
And she wanted to know how she could get a wheelchair because she talked to her endocrinologist who said, no, I want you to keep walking. I don't want you to use a wheelchair. And so she had gone to the local Pennies and bought one of these sling seat, sling back, airport type wheelchairs, which are really horrible. They are the most uncomfortable possible thing to sit in because they have no back or pelvic support. And her 10-year-old son would push her to the grocery store.
Goodness.
So they could buy groceries. And so my teaching to the students is here a collaborative care moment is lost. Because yes, it would be good for this woman with diabetes to keep walking whenever she has that opportunity or option. But when she needs to do tests, she needs to do them safely. And she needs to support her family. And so getting a wheelchair would be a very reasonable thing for her to do, to be able to use as she needs it in circumstances while she also tries to maintain her walking as much as possible. And so that was one of the major messages that I got from the people that I would talk to.
It's a moment where there's a real lack of understanding by the physician in this case, or even lack of openness to what it would take to live successfully for the patient. You've done interview work with patients. You've done interview work with clinicians as well, right?
Yes.
What have you heard from them?
Well, okay. Let me just say that I've probably interviewed over 300 people over the course of my research. And I've always liked to do the interviews myself because it's just really fun. And I like asking follow-up questions. Let's just put it that way. And so I published a lot of articles about the views and experiences of people with disabilities, primarily in 3 content areas: primary care, reproductive health care, and cancer care. That didn't get a lot of press coverage, publish them in articles where you were kind of preaching to the already believing types, like Disability and Health Journal, which is a great journal, but it was only once I started publishing about interviews with doctors.
Us, the important people.
Yes, the important people. that anything got a lot of media attention. And so, yes, I was very privileged to get a grant from NIH to do the first ever national survey of physicians about their perceptions of and experiences with caring for people with disabilities. And I had 3 serious survey scientists as collaborators on that project. And so we wanted to design the survey instrument right. And so what that meant was it started with me doing individual interviews with 20 physicians and then doing focus groups with physicians from around the country. And learned kind of the mirror image of what the patients had told me. Some of the things were pretty tough to hear. But one of the things that when you have a disability, you realize is that you should never say that you've had all the experiences that you possibly could as with a disability, because untold things are always happening. New things are always happening. And so I had thought that these interviews wouldn't really highlight things that I had never heard before, but they did. For example, I asked the individual physicians if they would print out in large font written instructions for their patients who had low vision and wanted the printed materials in large font. And the physicians would say to me in these interviews that they could not change the font on their printer.
My goodness.
And so they never printed out anything in large font. Also heard some kind of shocking things about how people with intellectual disabilities are treated, even for routine phlebotomy kind of things. And so we added certain questions to the survey based on those preliminary interviews. And so we have, we've published, I haven't even counted how many papers, but, well over a dozen papers from this project. A bunch of them qualitative papers from the interviews, and then a lot were the quantitative papers from the survey. Yeah.
One of the major papers was published in 2021 in the journal Health Affairs and drew quite a bit of attention. I'll say that we'll post a link to it in the show notes. There were 1,400 physicians who were administered a survey, 700 in primary care, 700 specialists, roughly in 2019, 2020, very beginning of the pandemic. At the end there were 1,225 eligible respondents. Some of the findings stood out to me were that just 41% of the respondents felt very confident about being able to provide the same quality of care to patients with disability. Also, I noticed that there was a question about welcoming people with disability, which seems like a gimme, I welcome everybody. Why wouldn't you just say that? Actually, 56.5% strongly agreed that they welcomed patients with disability into their practice, which means that a meaningful percentage didn't agree with that. Do I have that right?
Yes. Also, 82% of doctors think that people with disabilities have worse quality of life than other people.
Yes.
And
82%.
That was why I said that this needs to be the first paper that we publish.
Long ago, when I learned a little bit about health services research, I was shown this survey called the SF36, which asks questions about things that you can do, things and about your physical health problems and whether they limit whether you can do things like bowling. That was actually in the questionnaire, or golf. And in these questionnaires, which are supposed to measure health-related quality of life, the impact of conditions that you have on your ability to do things like bowling would take your score down. So a part of me, as I was reading this finding, thought, well, I guess in the world of this survey I once learned about and occasionally used for research, I guess your score is going to be lower if you have a disability. Wouldn't I just agree that there must be lower health-related quality of life in a person with disability because literally the survey I was taught to use makes it so? On the other hand, I read a little bit more and learned that a lot of people who have lots of disabilities say, no, my quality of life is pretty darn good. Do I have it wrong? How do we make sense of this?
It is possible for a single person to hold two what appear to be conflicting feelings simultaneously. Okay. So it is possible for me to say, there's some really awful parts of my MS. And I experience them every day. They're really pretty crummy. However, I get through them. I have other things beyond my MS that are of interest to me in my life. And I have pride that here I am. I'm still here 48 years later, after having my first symptoms. And so I think that it's having people outside of the disability community judge your quality of life is inappropriate because they have no experience with it. I mean, I've had people say to me, if I was you, I would just stay in bed all day with covers over my head. What? That's what you would do?
Free advice. I take it you didn't pay for this advice.
No. And these are people who I decided I didn't want to actually be friends with. And so I think that it's really, really important to understand that you can compartmentalize aspects of your life and have one aspect predominate, which is that you have an intellectual life, you have a social life, you enjoy art, you enjoy music, whatever it is that can give you a good quality of life. And these results came out around the time, I don't know if you remember that, March 28th of 2020, Office of Civil Rights in the U.S. Department of Health and Human Services had to issue guidelines.
I remember.
And the guidelines were that you cannot deny people scarce resources to treat COVID because of your perceptions of their quality of life. They actually say that right in there. You cannot deny scarce resources because of your perceptions of quality of life. And so that, really clarified that the fear of people with disabilities is that we are denied care.
Yeah.
Because of doctors' perceptions of our quality of life. And this goes back to 1927 Supreme Court ruling in Buck v. Bell that said that the state of Virginia had the right to forcibly sterilize a woman with a disability if they chose to do so. She had intellectual disability, was institutionalized in Virginia, and they were allowed by the Supreme Court to forcibly sterilize her. This was eugenics. We had eugenics before the Nazis had eugenics, and a lot of it related to disability. And by the way, that Buck v. Bell precedent in the U.S. Supreme Court has never been overturned. And so people with disabilities know this. We talk about Buck v. Bell, and so the kind of distrust of the medical profession just is part of the way that a lot of people with disabilities feel. But they will never reveal this to their doctor because they want their doctor to like them and keep their doctor. And so they will just kind of take it.
I'd love to get your thoughts about where we go from here as medical educators. Obviously this is a multifactorial problem. There's a need for greater education for physicians. And I think also physicians are operating within a for-profit environment where there's a lot of emphasis on throughput. I noticed that one of the comments from one of the physicians in your focus group said that he saw people with disabilities, quote, a disruption to clinic flow. And that says a lot, right? It's just this incredible attention to productivity and it's sort of almost an industrial model. And, these people slow us down, which obviously is a perverse way of looking at what, being a doctor is, right? But it's nevertheless, I think, captures a lot. So there's a lot going on here. But as I said, at the beginning, I was reflecting on the way in which people with disability may evoke a sort of fear among people who are often young early on, who operate within a profession that has put this primacy on being tough. I think you talked at one point about, not here, but listening to in another context, about how a doctor's supposed to be available 24/7 and all that kind of macho attitude. And so you can see how young people who become physicians are often perhaps terrified in the face of seeing disability because it may evoke for them their own vulnerability. And certainly if you think that having a disability means that your quality of life is shot, then that's going to cause even more terror because quite honestly, almost all of us become disabled at some point. Disability is part of the human experience. And at some level, I think we know that. And if we're terrified of it, and if we see in disability weakness, then we could be threatened by it and we could push it away and we could push ourselves away from it. And so I feel like there's a need for some conversation within the profession among medical educators about why the profession itself is so fearful of disability. It is so threatened by it and ultimately, in some ways, turns against it. But I would love also to get your thought. First of all, your thoughts a little bit on what you think is going on. Why is it that you've had this horrible experience in medical school? Where do you think we are now with disability? And what do you think is the connection between that culture of medicine, these anxieties, and the experience of patients?
There's a bunch of things that I want to say. First of all, I do occasionally get cold calls from medical students with disabilities who I do not know, but have heard about me and just want to talk. And this is from around the country. Okay, so I do not mean to impugn any medical school right now. But one of the things that we have seen in studies of race and ethnicity, for example, is that if you have concordance in the race and ethnicity of the patient and the clinician, that there is an improved communication, that there seems to be better outcomes. And so why do we only have something like 2% of doctors who, quote unquote, admit that they have a disability, even though we know, given how old the medical profession is, that probably a lot of them have some hearing loss, some vision loss, maybe a little arthritis, So one of the things that has concerned me about students who are calling me today, 2025, is that they're saying that when they ask for reasonable accommodations, which are supposed to be what you get under the Americans with Disabilities to ensure you get equitable access to training programs, they're told that they are being unprofessional.
Weird.
And that is totally wrong. Because students with disabilities or chronic illnesses, there are a lot of medical students with chronic illnesses, deserve and require reasonable accommodations to be able to have equitable access to their medical training. And so I think that if you're going to reject people with disabilities as becoming healthcare professionals, that's a first place where we're just saying, you are marginalized. We don't want you in our profession. I think that older doctors are worse than younger doctors in terms of their stigmatized attitudes. I think that a lot of that is because younger people have, from elementary school through junior high, through high school, had classmates who've had disabilities and have been, with them in the same classroom. And so they don't have the same kind of fear about talking about a wheelchair or talking about, ADHD or a learning disability. They just don't have the same fear. However, there is going to be a hidden curriculum in that if the older doctors have a highly stigmatized attitude about disability, which they do, we know that medical training is almost like apprenticeship. You go in and you want your attending physician, your preceptor, to like you, and so you behave like them. And so as you see the attending physician just simply yelling at the patient with hearing loss, at the bedside to try to get rid of them, as opposed to thinking about, would a pocket tucker help here? Would a microphone help here? Is there some other way that we could accommodate your communication needs? Mr. Smith, who's hard of hearing, the medical student just simply sees their attending yelling at the patient. They're going to emulate, and so I think that until we wash out all the older doctors, but we'd have to replace them with younger doctors who haven't had the hidden curriculum kind of imbued within them. And so I also get cold calls from people who are about to go to medical school but are really interested in disability. And often the young people who are interested in disability have a sibling who's disabled. That is the typical story that I hear. And so they just want advice from me about how to kind of, learn about disability in medical school and, come out as a doctor at the other end who will be great with people with disabilities. And I say to them, keep your eyes open and keep a notebook, not a paper notebook, metaphorically, but you can write little notes to yourself in a smartphone about instances that you see where disability is stigmatized, where the attending isn't doing the right thing. You know that you can't confront that attending unless it's really egregious, but you need to understand that the socialization that you are about to undergo will attempt to change the open attitudes that you have right now. And so you have to prophylax yourself against having your attitudes changed.
Yeah. And why do you think the system does that?
Oh, I think it's attitudinal. If doctors can't fix you, then, they automatically assume that it's their failure, but they don't want to have a failure, so it's your failure, and so I think that, that is a lot of it, actually.
Yeah. It's this perception by physicians that they have to somehow be in control.
Yes.
And it reminds me of another story you told in a different context where you described a patient who actually is a friend of yours who was basically forced by a geriatrician to be in a nursing home against his will. This was through a Medicaid, I think, or a PACE program, I believe.
It was a PACE program.
Yeah, PACE program. And the evidence was overwhelming that this was not in the patient's best interest in terms of developing
pressure injuries in the back. His backside was covered with wounds.
Yeah.
By the time he got out of that.
And the geriatrician was kind of a control freak. They were just insistent that this had to be the way. And it was interesting because it wasn't really clear why the geriatrician was so committed to the wrong path. And it just reminded me of the extent to which physicians sometimes seem to have this desperate need for control.
Yeah, that was my late best friend, Michael, who was, involuntarily kept in a nursing home for 3 months. And it's important to say that I was able to get him legal representation from a local disability civil rights organization. And so he was able to contest being held in that nursing home. Took months for the adjudication to come through, but the Medicare adjudicator said to that geriatrician, no, you need to send him home. He should not be in the nursing home. And the PACE program appealed that initial ruling, even though the PACE adjudicator had said, don't even think about appealing. They appealed it. And again, they lost. The adjudicator said, no, he needs to be sent home with personal care assistance so he can be in his own home and cared for by PCAs. Michael and I never figured out why she had that attitude. But I was tasked with trying to find Michael another doctor after he left the PACE program, which he had to do. And I remember calling one doctor who had come highly recommended and telling her that my friend has, a low flow bed. He has ceiling mounted lift devices to make it easy for the PCAs to move him. He has a PhD in physics from Oxford University. He knows how to program his entire house to be a smart home. And would you consider, caring for him? He will be in his home. And she said, it's my opinion that he needs to be in a nursing home. And how dare you ask me to do something against my judgment? And I was just calling her, asking if she would consider being my friend's doctor. And she, without seeing him, without meeting him, immediately assumed that this man could not live at home. And even though the adjudicator had ruled twice that it could. And so that was the end of that. And I did eventually find him an amazing geriatrician who was just starting her practice, who would do house calls with medical students, bring medical students to the bedside when she would come and visit Michael in his home. And sometimes those medical students would stay in touch with him to just find out how he was doing. And so they would learn from him. And I actually think that the house call thing is a really important issue to just mention. Doctors nowadays don't typically do house calls. And so the only time you see a person with a disability is when they are at their lowest, unless they're coming in for some sort of routine thing. It's when they're at their sickest. And so you have no idea how they have adapted their house to be able to live within the environment where they live. And so you make assumptions about what their daily lives are like that are probably totally erroneous.
Yeah. I think that if you look at it from the perspective of the socialization of the doctor, as you said, they have this perception that being disabled is terrible, that your life is over, that it evokes fear in them. There is a sense of vulnerability that they experience as a result of seeing it, thinking, oh, this could be me. That forces them to push people away. They become very controlling. They have this need to want to fix it. They know they can't fix it. They think they should fix it. And so there's all this sort of pathology that is part of the culture of medicine and medical training. It's devastating for individuals with disability, but in a sense, it's also devastating for the kind of person you become as a doctor when you live with that kind of fear. You have to hold people at a distance.
I think in reading Lisa's work and thinking about this, I think we often say, oh, no, I want to do the best possible job. My problem is that my time's limited and that they don't give me adequate resources. Otherwise, I am full of goodwill and want to do all the right things, but they don't give me what I need to do it. So I'm sorry. And I'm trying to figure out, is that true or is that 100% self-deception?
Well, you know something, I was surprised because as I was telling you before we started the interview, we did ask a specific question in the survey about time.
Yeah, time.
And I can't remember the specifics right now, but I thought that there would be an overwhelming response. Yes, we don't have any time. But in fact, it wasn't. It wasn't. You know, like maybe, again, I can't remember the specific numbers. We could probably find them. But it was not an overwhelming concern about not having the time that was the problem.
Yeah, I think as you said, that may be a little bit of a red herring. I mean, obviously time is an issue. I know that anytime you're caring for patients under a 15-minute constraint, time is an issue, regardless of whether they have a disability or not.
That's right.
And I also just want to briefly mention that you've done a lot of important work that just, I think, needs to be talked about briefly, which is the pragmatic issue of making sure that your office in your clinical setting provides adequate accommodation. And I know you've looked at this in your survey that, you can't even get into the door. The buzzer isn't accessible. You get into the exam room, the table isn't set up for you. Like all of these things.
No scale.
Well, all that stuff. And I know that I think it was around 2017 that there were some standards that were passed that sort of set guidelines. And I'm not sure they've ever been fully enforced. And so I wondered if you could just say a few words about that so that at least physicians who want to do the right thing have an understanding of where to go and where to look to make sure that they're providing appropriate accommodation.
So you did the wrong thing by asking me to say a few words about this. I had the pleasure of being the chair of that committee.
Oh, my goodness.
For the U.S. Access Board that advised the U.S. Access Board on standards for making medical diagnostic equipment accessible. It was challenging because that committee included everybody from General Electric and Philips Electronics to Minmark that makes, exam tables, to ergonomics people, to the Paralyzed Veterans of America, and people with disabilities. And so it was a really hard committee to work with, but it was just an amazing experience, with the exception that we never did come up with what should be the lowest height on height adjustable exam tables. Should it be 17 inches from the floor or 19 inches from the floor? And so the standards that were finalized in January of 2017, right before the Trump administration came into play, still say it can be 17 to 19 inches, but the basic standard is that you do have to have height adjustable exam tables. Now, the next step to implement this was going to be a Department of Justice scoping review, but the Trump administration decided not to do that. And when the Biden administration came in, we were hopeful that the government was going to immediately set final standards for requiring accessible medical diagnostics.
Yeah.
And so what happened was that May 9th of 2024, so just over a year ago, and then August of 2024, respectively, the first one was the Department of Health and Human Services updated Section 504, which I won't go into, but they were the first federal disability civil rights laws that were passed in 1973. And they specified that by July of 2026, every single practice has to have at least one height adjustable exam table and at least one wheelchair accessible weight scale. They also have some scoping that looks at, if it's big clinic, how many tables do you have to have? And so, the number of tables increases the larger the practice size is. And then the August 2024 rulings were from the Department of Justice, and they were for Title II facilities. Those are facilities that get state and local funding. So again, the May rulings related to places that get federal funding like Medicare and Medicaid, and the August rulings were places that get state and local funding. And so basically it is on the books that within 2 years, every place has to have a height adjustable exam table and wheelchair accessible weight scale. They did not make standards relating to other things that our committee had set standards for, such as imaging equipment, breast mammography equipment, with the expectation that that those would come later. But we do not know whether the current administration will enforce these regulations. And let me just say that that Javier Becerra, who was the head of the Department of Health and Human Services under the Biden administration, issued the proposed rules for these Section 504 updates in September of 2023 and asked for public comment. And so there were tons of public comments, as you might remember. But the people who wrote the final rules really got disability. And I know some of them, and they knew the lived experience of disability and have been disability civil rights attorneys for years. And so, for example, in the comments, there had been small practices who wrote in and said, you know, this would be a lot for us. Why should we have to do this? Do
Heavy
we really
lift.
need to do this? And the reg said people with disabilities have been waiting for 50 years. They shouldn't have to wait any more. Yes, you have to do this. And whenever I talk to physicians about this particular issue, I always say that, well, first of all, small practices can get tax credits for renovations or equipment that improves accessibility, or at least they used to be able to. And then I also say it's a win-win-win. Okay, it's a win for the patient because the patient can more easily transfer if they can independently transfer onto a height adjustable exam table. It's a win for physicians because physicians come at different heights, you know, and so if you have a fixed height table and you're a physician of smaller stature, it might not be as easy for you to examine your patient. Whereas if you're a physician of very tall stature, you might want to have the table elevated. And so physicians get to set the table at the height that's most suitable for them ergonomically. And then the third win is for practice staff, because if you look at occupational safety and health administration data, practice staff have
back
some
injuries.
of the highest rate of occupational injuries.
Yes.
Including career-ending
Yes.
injuries. And so it minimizes the risk for injuries. And so why would you not want to get, you know, one of these tables?
So for physicians who want to, and practices who want to make sure that they are providing the right accommodations, is this the document that they should be looking at? Where should they go?
Yeah.
I mean, I think that actually it's in the Federal Register, which is a pretty dense document. But there have been a number of articles written about this that you can get. I personally was involved in a couple of them. One is in the New England Journal and another is in JAMA. And you could even put them in your show notes or something like that so that people can see. But, you know, every practice, every institution has their own supply chain. And so I'm sure that the supply chains are working on this right now because it is a regulation that was put into effect, you know, in 2024. And so I know that this is being worked on.
Sure.
And I found some standards published in 2024 in the Federal Register just now. So I think that will be easy to share. So I'm struck that we've gone on a long journey from someone who was pretty sure she didn't want to be a doctor with early signs of an illness before you were ever in medical school to a life in which you're a champion for people in healthcare, partly based from your own experience and from your data and from your research and a guide for many of us as well. This is extraordinary kind of range. So often we wind up doing things we didn't think we were going to be doing. Would that be fair to say that about your life as well?
Well, that's what I tell students, that life happens. And, you know, it's better that I was the person who wasn't able to train than somebody who since age 5 wanted to be a doctor. And there are people who at age 5 decide that that's what they want to do, you know, and I feel very grateful for the career that I've had. You know, I've already mentioned that I had these wonderful colleagues early in my career who were very supportive, and I've had more than 300 people be willing to talk to me, and I'm very grateful for the fact that they were willing to talk to me. I've had colleagues who I've quoted. They may not have been so happy about that, but I don't put their names near where I've quoted them in places that I've used their language. But I feel very grateful for the career that I have. What I have not done, I haven't necessarily said wonderful things about our profession.
We rarely do that on this podcast. I am very thankful. Saul or Lisa, I'm happy to see if you have a final thought for us.
I think we've hit on this narrative where we connect, I think, the culture of medical training, the way in which that shapes the kind of people who become doctors, and in turn, the consequences for patient care. And
yes.
The fact that we need to be looking at that in its totality and in some of the ways in which that's a problematic process that ultimately has consequences for the psyche of the physician and for the people they care for. I also think that your work has provided a lot of practical guidance for things that we can do. But I'd love to see if there's anything that you think we've missed out on here that you'd like to add.
Well, I actually was impressed that Saul said this at the very beginning. That is, disability is pretty much a universal part of the human experience over the course of the lifetime. And I think that that is really important to remember. There's one other thing, the population is aging. And people tend to separate aging and disability, but they're really, they're different sides of the same coin. And also, people born with significant disabilities are living longer. They're living into early adulthood, middle age, later age because of medical advancements. And so I think virtually every physician who sees patients, be it the physician from a pediatrician all the way to an internist, is going to see more people with disabilities in their practice. And so I think it's just really, really important to consider ways to improve the quality of care that you give to this population.
Yeah, and I think the point you're making is that, as you said, disability and aging are part of the human experience. And being a doctor is about the human experience. It's about caring for humanity and also being comfortable with your own humanity and your own vulnerability. And that has to be part of the maturation process of becoming a healer. So thank you so much, Lisa.
You're more than welcome.
Thank you.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app, as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.